Hello, and welcome to another Facebook Live broadcast with MedStar Health. My name is Dr. Louis Weiner. I'm director of the MedStar Georgetown Cancer Institute and the Georgetown Lombardi Comprehensive Cancer Center. And I'm here today with Diane Tippett, who I had the privilege of treating several years ago for a rare metastatic neuroendocrine tumor. I'm really excited about today's broadcast because we're going to be discussing a very important topic, cancer survivorship. Sunday was National Cancer Survivors Day, and June is National Cancer Survivors Month. Fortunately, more than 2/3 of all cancer patients are now surviving their cancers. However, they face a multitude of aftershocks, problems that are associated with either having had the cancer or problems associated with the treatments that they received. And these can last for months or years after treatment. Diane's going to share her inspirational story with us today. At the MedStar Georgetown Cancer Institute, we are able to offer our patients tomorrow's treatments today because our research engine, the Georgetown Lombardi Comprehensive Cancer Center, is the only NCI-designated comprehensive cancer center in the Washington region. And NCI stands for National Cancer Institute. Through our partnership, we provide greater access to life-saving clinical trials and technologies closer to where our patients live and work, since our network of hospitals is able to combine medical expertise, the latest therapies, and research, screening, prevention, diagnosis, personalized treatment, rehabilitation, and survivorship programs. And most importantly, we can offer our patients hope, because we are all about giving our patients research-inspired cancer care. So stick around, and since this broadcast is live, share it with your friends, and please ask us questions and comments below after we're done. So Diane, can you tell us your story about how you came to meet me and the journey you took before you got here?
Sure. Probably December of 2013, I noticed a small bump in my mouth. Ended up finding out that it was stage 1 neuroendocrine carcinoma, and after surgery and treatment, which was basically 30 radiation treatments, 5 days a week for 6 weeks, which was kind of hard, but got through that. I was cleared. And then I ended up here, and I was doing my every 6 month screening. And in June of 2016, I was diagnosed with stage 4 neuroendocrine cancer. At the time, my oncologist didn't know a lot about it, so he sent me to Dr. Weiner, and I'm so glad he did. So I came up here, met with Dr. Weiner, and he approached this just completely different, and I wish he would explain it because he's much better at it.
Well, I think you did a pretty good job. But so when I first saw Diane, she had experienced a spread of her cancer to her liver and to her lungs, metastatic disease. And this was a tumor that was very hard to characterize and understand. And the toolbox available to oncologists of approved and effective treatments for this kind of situation was pretty bare. So I did what any good doctor working in a comprehensive cancer center environment would do. I turned to the science, and I said, what can I learn about my patient's disease that can help define how I should treat her? So what we did is we took a sample of her tumor biopsy from her original biopsy and sent it to the Caris Precision Oncology Network for an analysis of the tumor to figure out what were the mutations and other genetic and molecular abnormalities that might give us a hint as to what was turning this cancer on and that might be a target for cancer therapy. And I honestly didn't know what we were going to find, nor did I know whether or not whatever we found would be useful and helpful to Diane, but I knew that we had to try. So we sat down and I told Diane, listen, I want to send your tumor out for this analysis and let's see what happens. And so Diane, how did that make you feel?
I was thrilled by it, honestly. Radiation or chemotherapy was not something that I wanted to go through again. So when he told me that, I remember walking out and telling my husband now that that was exactly what I wanted to hear. I wanted to hear something other than the standard cancer treatment, which can have very harmful effects.
So, a few weeks later, I get the report back about what we had found. And what we learned is that her tumor had an unusually high tumor mutational burden, and it expressed a lot of a molecule called PD-L1. Now, PD-L1 is erected as a defense that cancers use to avoid being killed by the body's immune system. And a high mutation burden suggests that this tumor actually had a lot of abnormalities that the body's immune system might see and recognize as being foreign and want to attack. Armed with that information, I knew that we had to try a new class of drugs called checkpoint antibodies, immune checkpoint antibodies that would block the ability of the tumor cells to put the killer cells of the immune system to sleep. And so I called up Diane and I said, this is what we think we can do. And then we raced against time to try and find a way to get the treatment supported by her insurance company and to arrange for her to get her treatment not here at Georgetown, but actually out in Eastern Maryland, Southern Maryland, where she lives, so that she could get her treatments closer to home by one of the members of our MedStar Georgetown Cancer Institute. And that's what we did. And once that had been arranged, I basically told Diane, I will see you in 3 months. Now, I didn't know whether I would ever see her again, because she had a bad cancer, and I didn't know what was going to happen. And so 3 months went by, and she's scheduled to come to see me, and I get a telephone call from her. Do you remember what you told me?
I don't actually. I wish I do.
What she said was, I don't want to come in. And I'm thinking to myself, oh, she's not doing well. And she says, I feel great. My doctor says my cancer is doing fantastically well, and I don't see why I need to come in. It's winter time, and I don't want to make that long drive. Now, you understand that I spent some of my years of medical training in northern New England, and so I'm used to some real snow. You know, there is no snow in Maryland, okay? So nonetheless, I said, you got to come in. I need to know how you're doing. I want to see how you're doing with your side effects, and I want to take a look at your CAT scans, et cetera. And she said, I don't want to come in. So what happened was we cut a deal. The deal was she said that she would come back in 2 months with a repeat CAT scan, and I said, and when we do, we'll do a victory dance together.
Yes.
Do you remember what happened then?
I came in and we looked at the CAT scans, and it was amazing. What was it? The liver was shrunken by 50%.
Yep.
And it just was a thrilling moment. And we definitely did the victory dance. We
did a victory dance, and it was a marvelous moment for Diane and for me, because it was one of those few moments in a doctor's life where you can say, you know, I really made a big difference in this patient. Maybe another doctor wouldn't have done it, and it made me feel good. And to be able to help anybody, especially somebody as wonderful as Diane, was a real privilege. So this is the power of molecular profiling, of using science to understand what's going on with the cancer and leverage that information, turning that information into knowledge, that knowledge into power, a power that can cure people. Diane's tumor had reduced by more than 50% when I saw her that March. 6 months after we had originally met. Mm-hmm. And here she is now 2.5 years later, and as best as we can tell, her cancer is gone. It's just gone. And she's doing great. Tell us about your side effects. What were your side effects? No, I didn't really suffer any side effects after the initial dosage. I had a small little rash that my oncologist at MedStar St. Mary's prescribed prednisone for. 2 days of that, and that was gone. And then I never suffered another side effect from this. I always felt great. I mean, I worked, you know, I did everything. Yeah. So as a doctor, as an oncologist, I live for moments like this. I dreamed that this can happen. And the important message is that while it can't happen for everybody yet, we're making progress. More people are doing well. more people are surviving cancer, and we're able to accomplish this sometimes with side effects that are more severe, sometimes without such severe side effects. And it's thrilling to be a part of this new revolution in the way we treat cancer using immunotherapy. So there are now 15.5 million survivors of cancer in the United States. So dealing with the aftershocks is really important. And cancer survivorship, what we're talking about this month, is really an emerging scientific and clinical discipline, because many oncologists and many primary doctors really don't know how to take care of a patient who's received cancer therapies. They don't understand what to be worrying about in terms of cancer recurrence, what to look for in terms of side effects that might be long-term, that might be peculiar side effects that they don't ordinarily see in their practice. And so we're working on trying to develop this. And at MedStar Health, through the MedStar Georgetown Cancer Institute, we've created a whole suite of services for our cancer survivors to assure that nobody gets left behind. You may have heard previously about our cancer survivorship program in cardio-oncology, where people who have had potentially heart-damaging treatments can be screened to make sure that they're getting the right care and the right interventions when they need it, as an example. So research-inspired cancer care includes cancer survivorship. And it's just a privilege to be living at a time and working at a time where this can happen. So Diane, what can you tell us? What are your hopes and dreams for the future? And what do you want to tell our audience that as a lasting message from today's discussion?
I think that people should look into the new science of diagnosing or treating cancer. Obviously it worked for me, and I'm very privileged that it did. And make sure, just never give up. You gotta keep trying. You can do it, it can be done. I'm proof, and I'm very happy to be proof.
We're happy you are too.
I am.
Thank you so much, Diane,
No
for being a continuing inspiration to all of us.
Hey, I'll be back next year.
Okay, that's great. So I am told that we may have some questions. The first question I have is to tell us more about immunotherapy. So immunotherapy is different than conventional treatments. For example, surgery removes a cancer. Radiation and chemotherapy are designed to kill cancer cells directly. They don't require the support of the body to kill the cancer cells. The drugs or the radiation kill directly. And one of the side effects of these treatments is that sometimes the normal cells get killed as well, and that's why people have side effects. Immunotherapy has been defined as treating the body's immune system so that the immune system will take care of the cancer. It turns out that every cancer that grows in somebody's body has solved the riddle posed by that body's immune system to evade recognition and destruction by the immune system. So these tools that the cancers use to defend themselves against immune attack are paradoxically the Achilles heels that we can use to attack the cancers. So Diane received an antibody known as nivolumab, which targets the PD-1 immune checkpoint. And PD-1 attaches to a target on the cancer cell surface called PD-L1, which was the molecule that Diane's tumor made. And when those two molecules kiss, the cancer cell puts the T cells to sleep. And what the nivolumab does, it essentially blocks the kiss. It allows the T cells to stay active so that they can do their job of killing the cancer cell. And once you stimulate this, once you remind the body's immune system that there's a cancer there and that it doesn't belong there and that it should start doing something about it, the immune system does a great job. And Diane is living proof of that. There are other kinds of immunotherapy, many other antibodies that target different kinds of immune checkpoints. Dr. Jim Allison, a good friend of mine, won the Nobel Prize this past year for having discovered the original immune checkpoint called CTLA-4, and antibodies directed against CTLA-4 are sometimes combined with antibodies against PD-1 in certain kinds of diseases. And those combined therapies have transformed cancer care for certain diseases such as malignant melanoma, a malignant disease of a kind of a skin cancer. So, in addition to that, there's a lot of work being done with cancer vaccines, and they're showing some promise. And perhaps most significantly, there's a whole new form of immunotherapy treatments that have been developed called CAR T cells, where you take a person's T cells, you genetically manipulate it so the T cell is now programmed to attack the cancer that's growing in that person's body, and you inject that T cell into the person's bloodstream, and that T cell goes and does its job. And it has had remarkable and transformative effects in the treatment of children with acute lymphocytic leukemia and in other adult patients with other kinds of blood cancers. And that and related kinds of approaches promise to further transform the field of cancer care and cancer research. Other questions? In what other cancers is immunotherapy working? So, one of the interesting things about immunotherapy is that when it works, it really works well. People who go into remission stay in remission more often than not, it seems. And that's very, very encouraging, because typically with chemotherapy for metastatic disease, it can work, and it can work at a high rate, but unfortunately relapses are rather frequent. So the answer is that while the treatments can work, and when they can work very well, for most cancers, and probably 25 different cancers where we now have evidence of immunotherapy working, notably melanoma, which I described, Hodgkin's disease, non-small cell lung cancer, some breast cancers, bladder cancer, head and neck cancer, you name it. We're seeing remarkable benefits of immunotherapy in all those diseases, more often than not in a minority of the patients who are treated, and we still don't quite know how to pick the winners in terms of matching the patient to the treatment that they need to receive, and that's a subject of ongoing research and clinical trials and laboratory science, but it can really work very well. So there's an awful lot of exciting new work being done in the field of immunotherapy. It doesn't work for everyone, it's not a panacea, but boy, when it works, does it make a difference. Another question. If a patient is getting chemo or targeted therapy, but not immunotherapy, are they not getting the best treatment? That's a great question. Every person with a cancer is a unique puzzle to the treating doctor, and the correct solution to the puzzle differs for each person. For some people, immunotherapy is the right thing to do, and you shouldn't do anything else. For other people, targeted therapy or chemotherapy is the right thing to do. And for some people, a combination of targeted therapy and immunotherapy is the right thing to do. We just had our annual ASCO meeting, the American Society of Clinical Oncology meeting, and I attended a session where a speaker noted there were 970 new immunotherapy compounds in clinical trials at this moment. And he did the mathematics of saying how many 2 and 3 drug combination possibilities are there. And I think there's something like 138 million 3-drug combinations that are possible when you have 170 new agents. And that doesn't include changing the sequence in which you give these drugs or combining it with conventional drugs. So there's literally hundreds of millions, if not billions, of possibilities of how we can move forward. We obviously can't test each one of those in people. So we have to use science to help us identify what the best and most likely combinations are going to be, and that's how we're moving forward now. But at the end of the day, the right treatment for the right person at the right time is what we're after. We call that precision cancer medicine. And immunotherapy represents one of the most elegant and simple ways of thinking about precision cancer medicine, because it's targeting the abnormalities in the cancer that the immune system wants to attack. One other question. Can I explain why an NCI designation is important for patients? That's a great question also. There are 50 National Cancer Institute designated comprehensive cancer centers. We received our initial NCI designation here at Georgetown Lombardi in 1974, one of the first ones. This designation is kind of like a good housekeeping seal of approval from the National Cancer Institute. It's a way of telling doctors, scientists, and patients that this is the place where the work gets done. You know, I often ask the question, you know, do I want to be treated by a doctor who read the articles or the one who wrote them? And I always want to be at the place where the doctors who wrote them are giving the care, because they're the innovators. They're the ones who are working together in large comprehensive teams, leveraging science in the interest of our patients, providing the most outstanding new therapies, things like proton therapy, like novel immunotherapies, novel targeted therapies, overcoming resistance mechanisms through science. That's what National Cancer Institute designated comprehensive cancer centers do. And the other thing we do, we are expected and it is required that we reach out into our communities to make sure that the people who live in our regions are benefiting from the work that we do, that our work is designed to help the people who we are responsible for. And we do that. We establish things like the MedStar Georgetown Cancer Institute to make sure that our patients, wherever they live in our region, have access to research-inspired cancer care. We focus our research on the unique problems that exist in a particular area. For example, the DC metropolitan area has a large number of underserved minority patients who need our attention and need our help. And we are expected to and gladly take up the challenge of developing strategies to help our neediest patients. That's what we're about. And there don't seem to be any other questions. So with that, I want to thank you again, Diane, for being this ongoing inspiration for us, for letting us know how important the work we do is, because when we're doing it right, we see the living proof that we're heading in the right direction.
Yes.
And it makes it a heck of a lot easier to get up in the morning to come to work when we know that the work we're doing makes a difference. Thank you.
I'm sure. Thank you.
And thank you all for tuning in.